welcome everyone. I'm Sean Smith from MedTech Leading Voice here with Leon Doorn. And we are here to talk about cybersecurity for medical devices in the US, especially the eSTAR Cybersecurity Requirements. Before we get started, a couple housekeeping notes that I'm going to drop into the chat. Please ask questions using the Q&A button or the chat throughout. Start by dropping where you're calling in from into the chat button, and so that we can figure out who's here. And then the recording and slides will be sent to all of you tomorrow, approximately 24 hours after the event. You'll get an email from Zoom that says, here's the link to the recording and the chat. We will try to get to all the questions today, but if we can't, we'll try to follow up with you after the fact. I'm going to drop the contact information in, and then I just have a final one-sentence thing to read from our sponsor, Singular Security. Sponsoring this seminar offers a streamlined cloud security solution for medtech devices addressing the persistent threat of cyber attackers. I'm going to drop their contact information in, and please look into what they have to offer. Oh, and one more thing, if you're not subscribed to MedTech Leading Voice, please do so. Just go to medtechleadingvoice.com. Thanks. Leon, over to you.
Yeah, great. Thanks for the introduction, and thanks for the setup and for the invite for this webinar. So today we're going to look at the cybersecurity for medical devices in the US. And I think what's interesting to note is that a lot has changed since the recent introduction of the eSTAR. And the main changes are, well, let's have a little bit of a dive into where the changes are coming from. So
Tell
if you
us
look
a little
at
bit about you before.
Yeah, oh, yeah, good. Maybe that's it. I do have an introduction slide, but it comes a little bit further.
Okay, I didn't mean to interrupt. Go ahead.
No worries. I'll get on it. So maybe for those who don't know, back in December 2022, there was a Consolidated Appropriations Act, which actually went into effect in March 2023, that laid out additional requirements with regards to cybersecurity. The FDA responded, drafted a cybersecurity guidance, which was issued by the FDA in 2023 as well. Then the final cybersecurity guidance got issued by the FDA for QSR and submissions. And the eSTAR became mandatory back in October 2023, last year. So that's last year. And just in February, the eSTAR version 5 went live, which is now the mandatory format. There's no other option anymore for submitting a 510K unless you have a clear rationale and it's agreed mutually with the FDA that you'll use a different format. One thing that's interesting is that just last week, a new draft guidance was issued by the FDA, which relates more to the post-market requirements for cybersecurity. It's worth having a look at, and I think it's open for commenting. So a very brief update on why we're in this webinar today. So if you look at the differences between version 4 and version 5 of the eSTAR, clearly version 4 already required a risk management report with a clear cybersecurity assessment to be delivered as part of the 510K and a cybersecurity report. Then if you look at version 5, again, also the risk management report, the threat modeling, end-to-end cybersecurity risk assessment, SBOM, for those who are unaware of what that means, it's the security bill of materials. Also one with all the end-of-life dates, then one with the vulnerability, security, and safety risk assessment. Then also an assessment of the unresolved anomalies for cybersecurity. The cybersecurity metrics, what that means, we'll touch on it further on. Cybersecurity controls, the architecture views, the cybersecurity testing, the cybersecurity labeling, and the cybersecurity management plan. And now when you compare the two in terms of the deliverables for the eSTAR, it's clear why we're here today. And you can see that there's a very strong emphasis that has started with the FDA, and they're really clearly asking for a lot more to be delivered as part of cybersecurity. And again, this is mainly driven from regulatory changes, but also clearly, I mean, if you look at the recent years, a lot of devices are moving to software components, connected components, and the cybersecurity threats are increasing in the market as well as we see today. So it's not that strange that the FDA is putting up the bar. So if you look at it, the cybersecurity right now, and I find that interesting, it's the biggest numbers of deliverables at all in the eSTAR version 5. So in any other of the deliverables hasn't been that extensive. It's supported by extensive guidance. So I already called out 2, but there's a lot more guidance available with the FDA. Especially in the eSTAR form itself, there's a lot of boxes that you can click on for further information that provides a lot of information and details, of also references where you can look that up. And I would definitely recommend anyone to do that, because it makes it very clear what is demanded by the FDA. And clearly, cybersecurity is no longer an optional deliverable for software as a medical device, or even software embedded within hardware and medical device. So a little bit about me. So I founded Care.io. Care is an independent medical device consulting firm. We help companies specifically on quality affairs, but also regulatory affairs, and to some extent on information security. So information security here is more in the sense of implementation of information security management systems for ISO 27001. And then knowledgeable with regards to software medical device, and also software medical devices driven by AI, an active contributor to ISO and IEC standards. So over the last, I think, 4 years, I've been a member with the ISO community, specifically on SC42 and HC21. Those are the standard committees that develop standards around artificial intelligence. And then also within TC62, where TC62 is developing, for those who are unaware, specific standards with regards to medical device software and those that use AI. So there's currently, I think, a few standards on the development there, specifically aiming to address AI components. In 2023, I started a consulting firm, and that's a bit of my background. So for the agenda of today, we'll start with getting a little bit more into the detail on threat modeling. Then we'll head on to cybersecurity testing, the risk assessment, bill of materials, the risk management report, and the cybersecurity management plan. And maybe to kick it off, we'll dive immediately into threat modeling.
Before we dive into threat modeling,
go ahead.
let's launch the first poll question, just so that we can get a sense of launch. Hopefully this will work. Can everybody see it? Can you see it? Yes, people are answering the poll question. So go ahead and keep talking while they answer the poll question for the next minute or so.
Yep. So getting back to threat modeling. Again, threat modeling has been around for quite a while. It's not new. It's already described in other industries as well. It's never been that strongly pushed forward to medical device manufacturers. In the past, I know FDA was keen on getting cybersecurity information. How well it was actually following the threat modeling was maybe less relevant than it is today, because right now really FDA is asking you to submit a threat model. The threat model, and this is from the OS website, it's a structured representation of all information that affects the security of an application. And in essence, it's a view of the application and its environment through the lens of security. We'll touch a little bit more clearly on what that exactly means and how that needs to be implemented. Threat modeling is a process. It's not necessarily just a deliverable. So it means that you need to start planning it, and you need to describe somewhere what that planning looks like, how you do this, how you assess threat modeling. You can do it through a procedure or a specific threat modeling plan, or you can add a section on your risk management planning to describe how you're going to do your threat modeling. First, and I think this is with a lot of the risk management and also with other processes, clearly you need to scope what you're going to apply your threat modeling to. And we'll get to that, because this is in specific, the scope can be a little bit broader than what you might expect. The assessment methodology and the rationale. So for example, there's different techniques that you can use for threat modeling. For example, STRIDE is the most commonly applied one, but you also have kill chains, attack trees. When you read the guidance as well as provided by the FDA, in some circumstances, just using one of these methods might not be sufficient. You might want to consider using a combination of the methods, or you might want to decide on using just components of those methods. You need to define your scoring and acceptance criteria, similar to risk management. You need to assess the entire security lifecycle. So when you do your planning, make sure that you describe what the security lifecycle of your device would actually look like. And also consider who is involved in the threat modeling exercise. Clearly, as a medical device manufacturer, you will have the best knowledge and understanding of your device, but it might be useful to actually get external security experts that understand where the precise risks of the type of device you're making for the environment where you're introducing your device into will work. And it can help you to get a better output of your threat modeling. So going on. So the first step in the threat modeling is to decompose the application. So for example, you create a data flow diagram. That's one way to do that. And this is, I think, also where in terms of the scope, the data flow diagram should be end-to-end. So you don't just consider the application by itself. No, you need to really consider the application as part of the larger network where the application will run into. Because clearly the risks can come forth from the device itself, but the risks will mainly come forth as well from the external environment in which the device is introduced, the connections it has with other systems, how data is being transferred from one system to the other. So you consider the dependencies, the entries, the exit points, and also the assets, right? So if you look at this image, which is a simple image segmentation device running in a cloud environment, you can see that you need to consider where what data is stored. And because that's clearly right, I mean, the data is what you're trying to protect within your within the device. You need to define the trust levels with access, for example, and on top you can consider, in addition there to global system views, but maybe also multi-patient harm views. So where an attacker, for example, could spread to further other systems. Updatability and patchability views. How quickly can you patch a different components? There might be components that are way easier to patch than others. So in terms of all the layers, you might want to consider which ones are easy and quickest to patch. And the security use case views. So how the system responds, for example, in the event of an incident. Once that's set up, you need to identify your threats. And I'm not going to go through a lot of different methods here. I'm just going to use STRIDE. STRIDE, again, is very commonly used. So it's a very systematic approach to considering threats. I'm not going to say it's perfect, because it's not. And you might want to consider additional methods. So STRIDE is just an abbreviation or an acronym for spoofing, tampering, repudiation, information disclosure, denial of services, and the elevation of privilege. So if you look on the right side, there's a description and the potential security controls. So in the case, for example, let's look at one of denial of services, for example, any action that is attempted to deny access to valid users. And obviously the controls you want to embed is make sure that your device continues to be available to the end user. So the outcome of the access to deny for valid users will be that the device becomes unavailable. One of the things to consider as well is that you can look at a WASP website for additional information with regard to threat modeling, but also the top 10 of most commonly threats, and they will use STRIDE as well, if I'm not mistaken. Look one step further, right? So you go and assess and score the threats. So you look at your design flow that you've created with regards to security, and you're going to consider what are all the potential threats that are applicable to the setup. So in this case, I've marked a number of 3 orange dots on the overview, and what you can see is, for example, there's a risk number 1 where a threat actor would spoof the hospital's network's IP to trick the DICOM uploader into accepting malicious data, which would be one example. to, for example, the hospital staff denying the uploading of certain DICOM files. And without proper logging, clearly you cannot prove that they've done so. And then you see the third one where the DICOM data is in transit to the cloud is intercepted, it's altered. So in other words, tampered with, compromising the integrity of the patient information. This is where you see that the STRIDE provides you that systematic approach to considering what are the attempts on this design diagram where people can actually spoof the system. What are the types of denials that can take place within the system? And then the last part is what are the interactions and the items that can be tampered with? And then you take that approach to assess all the potential threats that you can come up with. You put them similarly, just like a risk assessment, you put them as your risks into a table. And for each of these, and this is where you have an interaction with ISO 14971, for example, in the case of the last one, if data is being tampered with, and you can imagine that will be patient data, there might be an additional safety risk. So in this case of segmentations, if the patient data segmentation image is going to end up in an incorrect patient file, then maybe in a patient that is the segmentation might not match actually to that specific patient, but the doctor might not be aware of that and could follow up on that for that specific patient, leading to an incorrect patient outcome. So these kind of risks do not necessarily be looked at in isolation for security. For most of these risks, you will have to consider, is this also a potential safety risk? And then clearly risks are prioritized. So the ones with the highest risk level, those are the ones, the highest threat level, those are the ones you want to consider first and how to mitigate them. You want to put your most efforts onto mitigating those. The next step will be to implement the controls. And in this case, I'm trying to give an example as well. So if you look, for example, for risk number 1, there's potential of 3 controls. The controls are also laid out in the image on the right side. So they will give you a little bit of an overview of how that will work and what that looks like and where you can implement controls. And I think in that, again, right, if we go one further in the last step, you can see that each of these controls you will need to provide in a single overview. And some of these controls are actually going to be considered your requirements of your software system. So your security requirements. Make sure that when you identify those controls that they're also seen as a requirement, because clearly your requirements again lead back to your verification and validation testing. And in the case of your verification testing, right, security requirement A is tested by reference of test 1, and you might want to do an additional validation test at the end, which can be a penetration test, for example.
Hey,
I hope
have
this
a question.
Yeah, go ahead.
One of the participants wrote, could you please contrast a bit threat modeling versus usual security risk analysis? It seems to be a lot of overlapping. What would you say to that?
Go ahead, sorry.
Yeah, I'm done.
Okay, yeah, indeed, there is a lot of overlap. So yes, there. If you look at a traditional software or ISO 14971 risk analysis, it's very much the same. It is a similar setup. Clearly, the deliverables that are the inputs into your threat modeling are different. For example, your design flows, the interactions, the method you apply to assess the type of threats that can occur for your system. You need to identify those. So for example, with the STRIDE methodology, and risk criteria that you determine can be different. The risk acceptability criteria could be different. Your overall acceptance of your security profile could be different from what you do in an ISO 14971. So I think the main reason for FDA to ask for this specific separation of the two is that if you combine the two within one single risk management approach, you run the risk that you overlook specific security risks because they do not have an implication on the safety aspect. And I think that's I
think that you just answered the other question, which was, does it mean that we need to do a separate cybersecurity risk analysis and medical device risk analysis following ISO 14971. And
Exactly. Yeah. So this is precisely what the FDA is asking for, is that you do a separate risk assessment approach to your cybersecurity risk management. And this is going to be a deliverable within your eSTAR. And literally, you cannot complete your eSTAR without having this deliverable done. So this is going to be a mandatory item from the FDA.
Okay, thank you. I'll stop interrupting now.
No worries. Feel free to interrupt. I mean, we're here to answer questions and to look at these methodologies. So it's a good question. Clearly, and this is also asked by the FDA, and I think there is a little bit of difference with the just purely technical requirements. It is always a bit the hard part with security controls. Not all security controls can always be tested properly. So in the case that you cannot test it, you need to provide a rationale. But these rationales will be acceptable if it is a valid rationale. And with regards to the validation testing, oops, I'm sorry, I just went back. With the validation testing, pen testing, for example, you also need to think about your testing your SOUP and OTS components, and also assess your OTS and SOUP components as part of risk assessment. One thing I'll mention here, and I think it's stressed in a number of times throughout the guidance by the FDA, is you'll need to demonstrate that traceability just like you do for your standard software requirements. So software requirements need to be linked to your verification test, need to be linked to your validation testing, and it needs to be traceable in both directions. Same with the threats, the risks. So that's not that different, but again, it's going to be delivered as a separate document for the FDA. So some notes, right? And specifically, I think on Stripe, but also this type of threat model that we just ran through. It's not extensive in the sense, so most of your controls can be addressed through threat modeling, but some may not. So some may require organizational controls, and I don't think there's an appropriate room in this type of risk assessment to do that. So when we talk, for example, about your internal staff members having access to certain parts of the software and being able to lose their login details somewhere, you need to have organizational procedures on top of having just technical controls. Make sure that your organizational procedures, for example, revoking access when a staff member leaves, right? You don't want to have staff being able to access a medical device when they've left your organization remotely. Training of staff, contractual agreements is also an important one. Some of these items you cannot mitigate directly. So if we go back, you can see, for example, for the first one, where I made it in orange as well, implement network level authentication. That is not something that is applicable to the organization executing the threat model, because this is really a risk within the hospital environment. In that case, you might want to request that the hospital implements appropriate controls. So you might want to put that in as a contractual requirement towards the hospital you're working with to make sure that your medical device is appropriately protected. One of the other controls that also do not come forth necessarily from the risk management, threat modeling exercise, are foreseeable security risks. So, for example, writing down passwords on a sticky note, just very simple example. I don't think that's properly addressed either through the threat modeling. It could be, but it might not always be. Another one to also consider is that threat modeling does not always strictly address post-market monitoring. For example, intrusion detection systems. When you write those down as control, again, I think that's more of an organization control. So it might fit a little bit under the same note that I have here. And for example, the ones that support the log investigations, I think we talked about it in the beginning. And Singular, the sponsor of this session, provides a rather good solution, which helps you to do intrusion detection and also can support some log investigations, which is really helpful. Then the last part, and I've mentioned it already, is not a replacement for safety risk assessment, right? They complement each other and they're intended to complement each other. And a risk on one hand for security could be a risk for safety on the other side. And sometimes, and that's also good to remember, is they can complement each other, but they can also contradict each other. So in some cases, you might implement security controls which limit access to a medical device, whereas in certain security alerts, you might actually, or safety alerts, you might want to get quick access to the medical device. But then if there's a lot of layers of security around it, it might actually limit access to the device. So you should always balance safety against security, and that might be a bit challenging. Some links and guidances. The FDA has worked together with me today to develop a playbook, which is specifically for threat modeling. It goes into a lot more detail on the threat modeling, the types of things to consider. And I really find it a useful resource. So I would really point everyone to read that document and look at that document when executing a threat modeling exercise. OWASP, clearly the top 10, but also their threat modeling explanations are really useful. So if we continue the software bill of materials, that's the next part on the list of items that you should be delivering to the FDA. FDA is requesting it to be machine readable, and it should be a list of the components that are within the software. So components of external origin, for example, SOUP and OTS items should be on there. So for example, open source items, but the ones you've purchased, etc. But also your internally developed software components should be on there, including, for example, your standard libraries. So why is this useful? Well, it will support the security and safety risk management process, clearly, and also your vulnerability management. If we look at what that means, what is actually an SBOM, what should be on there? So all components and subcomponents, the SBOM author, the date and time of the last revision. So in this, I gave a list of 3 examples of what could be on there in the cases of the device we just mentioned for the threat modeling exercise as well. So you see that there's a number of versions, the number of components on there, the versioning is on there, the relationship. And for example, if the Python code, and we all know that Python has a lot of sublibraries, you might want to list these separately. So you want to clearly describe that first component includes a number of subcomponents, and these subcomponents should be on the same list with a clear link going back up saying that these are included within X. So the references between those systems should be clarified. The level of support, so for example, whether it's abandoned, whether it's no longer maintained, or whether it's actively maintained, and the end of support date. And clearly, it's just for the purpose of this example, I noted that the first one is abandoned and is no longer supported. If you look then, and I specifically called out version 3.7, so we can use it to show how you also assess the vulnerabilities. So you have all your components, then you can have you can assess the available CVEs. So for example, the CVE database from me today, I found really useful. It's a little bit more extensive than the one that the FDA refers to, the CISA-Gov one. And then you will find that, for example, for this specific version of Python, there is a known vulnerability, and you need to assess, is that vulnerability applicable to my device? In this case, for example, yes. And it gives an attacker, in this specific example, the option to create infinite feedback loops, which would block the current process and can utilize a single core of CPU by 100%, meaning that it would no longer be available to do any other type of activities. If you see that kind of vulnerability, you need to assess the probability of that occurring in your device, the severity, clearly, again, the risk, and it can feed back into your risk assessment for cybersecurity devices and how you're going to mitigate this. If you decide to keep this in the device, or if it has a very high risk, for example, you might want to release a patch as soon as possible to patch it, if that patch is available from the manufacturer. I think you want to ask a question, Sean.
Yeah. Someone asked, what does level of support mean?
The level of support is, if you Google actually on those, or you just provide a search term on Google and you look for the level of support, it's clarified. I know the clarification here is not entirely clear. These are not my definitions. This comes from the FDA guidance with regard to abandoned, no longer maintained, and actively maintained. I would have to look at the exact definitions as provided by the FDA. But it means that if it's no longer supported, for example, so the manufacturer will publish it, they will actively publish patches to the device. That means that it's actively maintained. At some point, they may still have it available. You can still download it and they still promote you using it, and they're still investigating it and supporting it. But at some point, they will abandon it and say, okay, you are no longer supported by the manufacturer, so we don't publish any patches anymore. So if you continue to use that specific component with that specific version, and there are security risks in there, then it's up to you and it's under your own responsibility, and we will not take any responsibility for any issues that have occurred with it. Maybe something which is interesting to note is the image above, right? Is consider that there might be all the modern digital infrastructure. There can be so many subcomponents that at some point you might be leaning on the use of a very, very tiny subcomponent that's somewhere tucked away all the way underneath that's no longer supported. And if that one actually is becoming a problem or raises a security threat, your whole system could suffer from that. Do you want to say something about the question, Sean?
Just that we launched the second poll question so that people would have something to do. And thank you all for answering the poll questions. They really give us a stronger understanding of who's attending and what you're interested in learning more about. So it's very helpful for future programming as well. I can't see the questions right now. If you can look at the Q&A and see if there's any. There was also a chat that popped up with another question about what you were just talking about.
I think there's quite a few questions. Is it helpful to do that now, or should we go through them at the end and see if we have time?
We go through them at the end. I just thought that, well, okay, I'm going to end the poll. So it looks like 62% software as a medical device, 31% connected device. These are not mutually exclusive. So, just to give you an idea of who's here, share the results. You can see, very interesting. Okay, let's keep going. Sorry to interrupt.
No worries. So going further, so unresolved anomalies, right? So you might have, during your design and development process, you're required to identify the unresolved anomalies. So there might be items in your device that are not, that you know that there's a bug in the device. And clearly you want to follow up on those post-market to resolve them. You may have a rationale on why it's acceptable, but the FDA is also asking you to assess the risks associated with the unresolved anomalies. One way to do that is suggested by the FDA is also to look at the common weakness enumeration. It's a public database. It's published on as well on MITRE. And you can just search. It gives you a very good option to scroll to certain items and see if your type of vulnerability or your type of anomaly is listed and what type of security risk is associated with it. And it will give you also an idea of whether you should be using that in your device, yes or no, and under what conditions. In this case, you see that the one in the example below is acceptable, but there's also a bunch that are unacceptable, for example, for having those available in your device. And this is specifically related to known medical device issues. So it's a good database to have a look at. Security metrics. So the FDA is asking you to give data about cybersecurity metrics. When I first read it, I find it a bit odd because they're asking you to provide cybersecurity metrics that you are aware of your device. So not just what you're going to measure post-market, but they actually want to have the metrics. Sometimes you might not know what those will be because simply your device is not on the market yet. And then in that case, the FDA is saying you can use prior model data if you have any, or otherwise, it's a bit unclear. I guess you need to indicate what you will be monitoring when it goes onto the market. Clearly, you should have the cybersecurity metrics throughout the full supported device lifecycle. So when it's on the market, it should demonstrate the effectiveness of your processes and they should be measurable. There are 3 identified by the FDA, which are saying that you'll need to do. So for example, the percentage of the number of vulnerabilities that have been patched, updated, which I refer to as your defect density. The average time between the vulnerability identification and the patch release. So how long does it actually take you to identify a vulnerability and to develop a patch release, which I refer to as your defect resolution timing. And the last one is your patching rollout timing. So from the date that you developed the patch, you installed it with all the sites, how long does that take you? And FDA doesn't request this, but I would really recommend that you split this into separate risk categories. So for example, high versus low risk vulnerabilities. And the reason to do that clearly is that sometimes you might have in your system a number of low risk vulnerabilities, or they might not even be applicable because of the way your device is developed, and you will just run a patch in the future when the next minor release is coming up. Then clearly you're not going to, at that point, roll out a patch because it doesn't make too much sense if there's not really a risk. But that is going to influence your security metric in a negative manner. So if you split them up, you have a good way of showing that you really address the high risk items immediately, where the low risk items you might not be as fast for. Then I would say that at the end, and I think this is going to be your catch all in one cybersecurity risk management report. So you really in your risk management report are going to describe everything we've talked about, your flow diagrams, explaining them, explain the users, the boundaries, the user environment, explain the installation environment, what your security objectives are going to be, the security lifecycle of your device, the security coding standard, the secure coding standards that you've applied throughout development. And then also the security risk management methodologies that you've applied, explain them, explain the scoring metrics, explain how you got to them, why these are relevant, explain the interaction with the safety risk management. So where you've considered or how you've systematically assessed all your cybersecurity risks, if they can have an effect on your safety parts as well. And clearly the security risk management team that was involved. You can also specify the secure verification and validation testing that you've done pre-market and attach the test results as necessary, and clarify the remaining vulnerabilities, anomalies, but also your labeling aspects. So how does this link back to your IFU? Are there any warnings that you might need to address straight on the device itself, for example, as warning messages, alerts that pop up within the use of the software, or maybe potentially on the product label? And your conclusions from the risk management process, and clearly with a reference to the cybersecurity management plan. And I would suggest that since you don't want to get a convoluted report, you can attach a lot of those things as your attachment. And by doing so, right, having the secure diagrams as a separate appendix, having your risk assessment as a separate appendix, having your security controls as separate appendix, and so on, that will allow you to separate these appendices out to submit to the FDA as deliverables as part of the eSTAR submission. So you have one collated document that you can maintain over time without having a big number of cybersecurity documents living within your technical documentation and design history file.
That's a tremendous amount. Let's launch the third and final poll question. Poll quizzes. Sorry, this thing is launch. Yeah, there was a lot there. Someone asked how should all of this be included in the post-market surveillance? You had sort of addressed that in the last slide, that there be a post-market surveillance plan. I was a little curious about that.
Yeah, this is exactly what's on the screen now, right? The cybersecurity management plan. So this is going to explain how to follow up on the pre-market anomalies and vulnerabilities that you've had when you're going to implement the patches, for example, to those, and how relevant those are, but also your references to the procedures that you have for cybersecurity monitoring, and potentially even a more detailed monitoring plan. But also your periodic security testing. So you're going to do pen testing, or you're going to do process verifications, retesting of security controls in time, and also your patching policies and the release process. So I didn't put that here, but clearly the security metrics that we just discussed, they should be in your cybersecurity management plan as well, because you want to demonstrate how often you're going to assess those security metrics and you want to monitor the security metrics over time if you see trends, etc. And in the past, I've included this as part of the post-market surveillance plan, but that might not be very helpful if you're doing an eSTAR submission to have it as the same document. It could, although you could potentially, I guess, attach it as an attachment to your post-market surveillance plan, and then I say separate it out and submit it as a separate eSTAR deliverable. And clearly, you should have a vulnerability disclosure process in place. So when you have a vulnerability that you find in your software that's out on the market, how are you going to inform your customers so that they also know if they need to take further action or need to take mitigations to prevent that being exploited in the field? And I think then that's some more useful resources, I guess, to look at. Again, the meter, I would really look into that. They have more documents than just the threat modeling. Also, the A meter 57, which is aligned with the ISO IEC 81001-5-1. Both are already recognized by the FDA, and then the ISO IEC standard is going to be harmonized probably within short notice within the European Union as well. So these are two standards that can really help you to embed these deliverables into your standard software lifecycle processes. And that's it. So we've come to the end of all the slides, and I hope this gives you a little bit more insight of what is expected within the eSTAR process. I hope it didn't cause too much fear already, because to be honest, I mean, there's not going to be a lot of us who've already gone through this eSTAR process. So yeah, it remains yet to be seen how we're going to get through, but we'll see.
That's wonderful. Thank you. So we have some questions. Do you want to try to address any of them?
Yeah, I think it makes sense. We have quite a few. I think there's 21 questions, so maybe we can
get a couple
run through
out.
Exactly.
Yeah, there are a lot of questions. I'm gonna look for, while he's answering some questions, I'm gonna look for the email address that the FDA gave me for cybersecurity questions that you can address directly to them. And they have an email address for sending questions to, and so I recommend doing that as well. But let's try to answer. So Petra, somebody asks, is there a penetration test strictly necessary for software as a medical device, or are there any alternatives?
I think at the end of the day, it ends up with your risk management process, right? And it would really depend on what your device is doing. I mean, I can imagine there's clearly devices that are not going to be connected to the public internet, which are software as a medical device that are used in isolation. And in that case, a penetration test may not be the type of testing that's most relevant after you release the product onto the market. I think you will have to have a very clear rationale to the FDA in explaining why you're not executing a pen test. But I'm sure that there's ways in specific situations where rationale may be acceptable.
Excellent. Should the cybersecurity metrics be part of the post-market surveillance reporting? We answered that.
Yes, indeed. I'm also seeing a question on whether cybersecurity requirements are also mandatory for Class 1 510K exempt devices. Yes. I think it's a super good question because one, there's a regulation, right, that requires you to implement cybersecurity controls. You do not need to clear your Class 1 device through the FDA by means of submission, but I would still ensure that you clearly have a cybersecurity threat modeling process in place and you assess what security risks are associated with the use of your device, if not only for preventing your company being liable for the device data being breached or for causing a security incident within a hospital. Any more questions that you've ran into that you want to discuss, Sean?
Yeah. I mean, any of them that are listed are good. There was one about the EU and the US and your recommendation for sort of not doing double the work.
Yeah, clearly, that's also a super cool question, and I think I may have already slightly addressed it. The ISO 81001-5-1, that standard is already recognized by the FDA. It will be harmonized soon within the European Union. There's a lot of questions being raised as to why it's not harmonized yet, because it was planned for harmonization beginning of this year and it's not yet done. But I expect that to be done any day soon. That standard actually already demands that you determine your product security life cycle. You have a question? Sorry.
Sorry, no, I was trying to find that email address and I accidentally hit a podcast.
No worries. Okay.
I'm gonna have to follow up with the email address afterwards, because clearly doing too many things at once is not my forte.
Yeah. And yeah, to finalize the question, so I lost my train of thought, sorry. Do you remember, Sean, what the question was? Then I can...
It was about the EU and the FDA.
Yeah, exactly. So implementing ISO 81001 is probably a good idea because it addresses the cybersecurity lifecycle. It addresses the exercise of threat modeling. It also addresses, for example, the need for penetration testing and documenting those. And it really fits in with the IEC 62304. So it demands you to document the requirements and risks, ensure traceability between all of those. So that's a good starting point, I would say.
Do you have, or is there a template that they can use for cybersecurity risk assessment?
To be fair, I do not have one today. I know that there's companies that have that are making templates available. I am not sure how useful it is to call these out, but I know that some of the requirements management systems, for example, have those. I know that there's a consulting firm here within the EU that makes available a lot of templates online. They're called Open Regulatory. They were thinking about making templates available online as well. But I haven't seen them doing that yet. So it might be one to monitor.
Here's an interesting question. For devices submitted pre-eSTAR program, is it expected to see more scrutiny of the FDA during inspections regarding cybersecurity requirements?
My expectation is that that will be the case, but how that will work out in practice remains to be seen, right? I mean, these are now the new requirements and they're backed up by regulations. So in that sense, the FDA inspector should be aware of these changes in regulations and should actually audit against them. So yes, I expect that, especially when also the harmonization of the 81001-5-1 standard.
You talked about likelihood, but the FDA guidance also talks about not using likelihood but exploitability instead for vulnerabilities. I'm not sure I understand the question, but
yeah, I do, and I think exploitability is indeed, I agree that that is probably a better term to use because it's the risk of a cybersecurity threat actually being exploited in the field. So even though the probability of that occurring in your device could potentially be high, the risk of that ever being exploited could be relatively low. So for example, to make it as practical as possible, if you look at exploitability, if you have a device, and I think we touched on a specific example of the PDF file that could cause a full use of the CPU system because it creates an infinite loop. If your device doesn't even have an opportunity to create PDF files, then that clearly is not exploitable in your device, even though that vulnerability may be present within the device. So yeah, I think exploitability is a good term to use instead.
There's another interesting one. Some suggestion about legacy devices or transitional devices. How can we manage the cybersecurity for those devices?
So if you look at legacy devices, you clearly assess the risk that comes with the legacy device. And maybe one question back is, and maybe Sean, it's clear in the question, but is it regarding a legacy medical device that's still on the market, or is it about a legacy component that's embedded within the device?
I think it's a legacy device that's still on the market.
Yeah, then clearly you should just maintain your security lifecycle process, no doubt, and make sure that you patch it. I mean, there's a risk, right? There's a security risk associated with the device. If you need to have all the documentation that is mandatory by the eSTAR, I don't think so, because you're not going to submit it as a new 510K. But I would make sure that you have clear processes in place to exercise the risk management on that device and exercise an overview of all the vulnerabilities that are associated with the device while it's still out on the market.
Interesting. So there's going to be a short survey following this. Please, so here's a question. Please recommend any certificate or recognition on cybersecurity for medical devices, if any. I guess it would be the ISO standard.
Yeah, indeed the ISO standard, but you can't really get a certificate against it. So I'm not aware of a specific ISO certification that you can get on a product level. As an organization, what you might want to do is consider implementing ISO 27001 and get a certificate against ISO 27001. Though ISO 27001 is, I would say, it's not tailored towards medical device industry. Two, it is rather lenient. You can decide yourself what controls you implement within the device, rather than it actually demanding that you are strict in what you implement. And you can also limit the scope to not even include the device aspects. So if you want to do a proper certification, maybe ISO 27001 is not going to be sufficient to demonstrate that you fulfill the cybersecurity requirements. However, it will establish a good framework for assessing risks, for making sure that you decide how to implement the measures, that you have a sort of system in place. But there's not really a good certification that you can obtain today, as far as I'm aware.
What kind of medical devices require cloud security specifically?
Well, any device that is connected, I think, one to the internet, to the public internet, in that sense.
Good.
Because as soon as your device is connected to the public internet, then it can be attacked over the internet.
Someone asked, would you recommend to use CVSS for determination of the exploitability?
Yeah, clearly, yes. That I think is very helpful, because they clearly have if you look at the CVSS, you can clearly trace back and understand how likely it is that that item will be exploited. But that's just only part of the question, right? Because your local implementation will change the exploitability even further. I mean, if you implement it in a certain manner, then maybe it cannot even be exploited at all within your system, and it might not even be applicable, even though a CVS actually exists, or CVE actually exists.
Someone asks, in practice, would you suggest having a new separate SOP for cybersecurity risk management, or incorporate cybersecurity risk management in the existing risk management SOP?
Yeah, so what I've done in organizations, and I think there's multiple answers to this. I think the basic answer to provide is that on what I've done in organizations. So actually, risk management procedures can be awfully specific. So they can detail already quite a lot in detail what you're going to do, how you're going to do it, following ISO 14971. explaining sometimes I've seen the risk acceptance criteria and the risk scoring criteria being explained in risk management procedures. If you ask me, the risk management procedure should be a basic outline saying, identify all risk management activities will be done according to a risk management plan. In your risk management plan, you identify the members of the team, you identify the risk management methodology, you identify the regulations that apply to the risk management process you're going to execute, and the standards that apply, and then you're going to make that much more specific within a risk management plan. And I would keep the risk management procedure much more high level and much more process oriented rather than actually detailed, because then you can just apply it for different types of risk analysis. Also, you already see this as an example where it becomes difficult is in product versus process risk assessment, where risk assessment procedures usually aim to address both. But then if you try to add a specific security risk assessment, then it becomes a bit of a hassle. So I would make them as general as possible, so it can address all types of risk assessment.
Interesting. Would this apply to devices not directly connected to the internet, but accessible via Bluetooth? Huh. I think Bluetooth is directly connected to the internet. No?
Not necessarily, right? You could have one device connecting to another device just using Bluetooth, and it would not have an active connection to the internet.
I see.
So, but it would still apply, right? You would have the same diagrams. Bluetooth can be exploited because it has a local access point. It just might have a much lower risk profile as compared to a connected device that's connected to the open internet. So clearly it has a very different structure, but the process of doing a threat modeling would still be the same, and the requirements that you need to fulfill when you're submitting your 510K are going to be the same. So yes, you should do the process. You should follow these processes. The outcome might be a very simplified version of that whole setup.
The last question that I'm going to ask before we go to the survey is thoughts on the latest draft from the FDA select updates for the pre-market cybersecurity guidance section 524B of the FD&C Act. What?
Yeah, exactly. This is the guidance that was released, I think, last week. I unfortunately haven't been able to analyze it in that much depth yet. So, I cannot make an active statement on it. Sorry.
That's okay. That's okay. I thought that might be the case. So I'd like to thank Leon very much. We will try to follow up with the questions. I will also send the link to the FDA for their cybersecurity question answer line. They should be able to help you if we cannot. Please connect with Leon, connect with me, connect with Singular, and look forward to the next webinar. If you have suggestions for me about upcoming webinars, speakers, topics, etc., please let me know. And thank you everyone so much for your participation.
Thanks, Sean, for the organization.
Take care.